us for our Meet Me at Treatment Planning webinar. This webinar will focus on breast cancer, and we have Dr. Ben Smith, Dr. Kent Gifford, and Dr. Lauren Colbert from MD Anderson Cancer Center to present today's webinar. Before we get started, I would like to go over a few items and tell you how you can participate in today's event. Today's event is being recorded. After the webinar, participants can go to the AstroArrow website within 5 business days to review the link to the recording. All participants have been muted and are in listen-only mode. We encourage you to ask questions. Dr. Smith and Colbert will answer your questions at the end of each case presentation. To ask a question, click on the white triangle next to the word question on the menu bar to expand the question box and type your question in the box provided and hit enter. Along with the link to the recorded webinar, we will also post answers to the questions from today. If you ask a question and we weren't able to answer it today, please check the website next week to see if your question was answered on the document. I will now turn the presentation over to Dr. Smith and Dr. Colbert. Dr. Smith?
Welcome, everyone. It's an honor to have you guys joining us to discuss our cases today. Sorry, I have the CT images. Did I accidentally delete the cases? Or do you have your
I have the cases, yeah. I can read them whenever you're.
Okay, yeah, why don't you just read it? Yeah, great.
All right, so we're gonna start with our second case actually. So this is a 48-year-old female with a T1A N0 invasive ductal carcinoma of the left breast, intermediate grade, ER/PR positive, HER2 negative. She was treated with breast conserving surgery with sentinel lymph node biopsy, which demonstrated negative surgical margins and negative sentinel nodes.
Excellent. So this patient came for simulation, and let's see, I'll just show you a picture of how we set up this patient. Or why don't we do it like this?
Trials are in the top.
Great, thank you. So at MD Anderson, we typically set our patients up supine on a sort of like custom breastboard-y thing that we designed. So it's basically just an angle board, and the patient lays on that, and there's a vac lock that the patient lays on that's on top of the angle board. And the vac lock is essentially shaped like an L, so that the vac lock can go underneath the patient's elbow and then underneath their torso as well. And then we obviously have them lay down, we suck the air out of it, and we most commonly will set up patients with about a 10-degree slant on the ankle board. And then that proves to be a very nice way to treat patients on a daily basis. So before I scan a patient, there's a gazillion right ways to mark a patient. And for this particular patient, she had had a segmental mastectomy and a reduction in mastopexy. An oncoplastic surgery, if you will. And so what I did was I marked her surgical scars, which you can see here. So I marked 12, or maybe Lauren marked. Maybe Lauren did all the work, and I'm just taking credit for it. 12, 3, 9, 12, 3, 6, and 9 o'clock around the areola, marked this vertical mastopexy incision, and then hers kind of went off in that direction. And then I place a superior wire. A common mistake residents make when they start rotating on my service is when we're treating the whole breast alone, they put their superior wire at the bottom of the head of the clavicle, which is what we typically use as a match line when we're treating patients comprehensively. But when you're just treating the intact breast, the clavicle doesn't really matter at all, and you're essentially just trying to palpate the superior extent of the breast tissue and put your wire there. That's relevant because some of our patients look like they could have given birth to linebackers who could play in the NFL, and they have very short squat necks, and they have large breasts, and they go very high, almost to their chin. And so in that case, you can like miss half the breast tissue if you put the wire or the superior edge of your field at the head of the clavicle. We also marked an inferior border. The textbooks would tell you to put about a 2-centimeter margin from the inframammary sulcus to your inferior border. I typically make my border a little bit tighter than that, typically about 8 millimeters. With our setup, it's very stable and reproducible, and you just don't need to treat the abdominal wall, and so you can avoid that toxicity. I tend to just mark midline as a starting place, and then I tend to place my lateral wire, which is honestly almost irrelevant, but I kind of do it for historical sake, and around the mid-axillary line, or sort of at the posterior edge of the breast tissue. So that's what I do before I simulate a patient, and then we simulate the patient, and we'll place setup marks on the patient. Should we talk about how we set patients up? So what we do in our practice, and we actually have one of our physicists on the phone call as well. So, you know, if when I start to veer off course and say the wrong things, can correct me. Not sure why all the points aren't on here. Oops, let me turn this. Okay, so the tangent, where is this? Mark tangent isocenter is here in blue. I'm just not sure where the first set red is. Kent, am I missing something? Is there a first set red somewhere that I am?
There should be.
There should be, shouldn't there? Okay, so I'm not a moron. So what we typically do is, I can actually just show this here, so I'll add a point. So we will place a point on the patient, which we call the first set red, which is typically about right here. Let me make this bigger. So the idea is that we place a mark on the patient's skin to the lateral extent of the breast, where the setup is going to be relatively stable, so right here, and then the medial edge of the breast about right here. And this is basically the first place that we mark on the patient. Is that right? I think that's right. And then our treatment ISO, essentially, we can set up to this point, and then we can translate the couch and end up on this point, which is what we're using for the setup. And then we can mark this on the skin also, the ISO blue, and that can give us another, wait, I'm kind of wrong, aren't I, Kent? We typically mark about this point as the setup point, right?
Yes.
Okay.
You want to choose two spots where you have an anterior that's flat and a lateral that's flat. That way it's easier to mark.
Yeah, thank you. And so we would initially set up to this point, and then we drop the couch, and then we move the couch, and we end up on this point as the treatment. And we'll also mark these points on the skin surface as well. So it's basically a redundant way of marking the patient to minimize setup errors. Is there anything you want me to add, Kent, now that I've kind of butchered that, or that you'd like to add?
Well, so if this is a chest wall, correct?
This is actually an intact breast, where I ended up adding an IMC field just to cover the medial breast.
So it's almost comprehensive. So for an intact breast, we would put the first set red, we would split the sternum with the anterior mark. So you just move it over a little bit,
yep.
But using an item, yeah, right about there.
That, right?
Yeah, that's correct. That's what we do for intact.
Yeah, thanks. So we would have set up points on the patient's skin here and here, and initially set up to these points because this is a very stable place to mark the patient. And you can start there, setting up to there, and then you just drop the couch and move the couch over, and you end up on this point. And then that should also mirror what we've drawn on the skin here and here is the ISO blue, and that's the treatment isocenter. Great. So thank you, Kent. I'm glad you're on the call. So then, you know, there's this mantra in radiation oncology of target technique dose, which is extraordinarily helpful conceptual framework for thinking about how do you go about treatment planning in any part of the body. And so for this patient with early breast cancer, the target is really the tumor bed. Well, the initial target that we want to contour is the tumor bed, and then the whole breast is also the target as well. So in this particular patient, Lauren probably did all the work, so she contoured the tumor bed. Okay, which target is that? That may be the target. So I'm just going to show you that contour. So to the extent that you can train your surgeons to put clips in the tumor bed, that's extremely helpful. And so this was our best guess of a tumor bed, just based on where the clips were located and where we could view postoperative changes. I have to say that, you know, if you had me contra the same tumor bed 10 times in these patients, I'd probably come up with several different answers. But I think the main point is that you just want to ask your surgeons to put in clips and then try to contour the postoperative changes. And what you'll notice right away is that this is a difficult situation where the tumor bed is very close to the LAD and close to the heart itself. And so the challenge for this patient was how to come up with a treatment plan that would optimize whole breast coverage, which is our intended target, and minimize dose to the heart and specifically dose to the LAD. Because you could have a great mean heart dose and still torch the LAD and give the patient left main disease in a decade or two, and that's kind of a Pyrrhic victory, even though your mean heart dose is good. So let's see here. So Lauren kindly set up this tangents only beam pair. Now let me turn this on. And so the interesting thing about this tangents only beam pair is, so she basically designed this exactly as we'd mark the patient, with the beam entering and exiting at the wires. And this is very nice because this has good geometric margin around the tumor bed and would cover all the breast tissue, but it's essentially going straight through the LAD. And I would posit that giving this LAD a dose of 40 and 15 or 50 and 25 could meaningfully increase the long-term risk of coronary disease in this vessel. And so that's really not a great strategy for this patient. And so as an alternative approach, we engineered the following solution. So we can look at the beam configuration first here. So we have medial and lateral tangents. Oops. And we'll step through these tangent beams in just a second, but just scroll through on the axial slices. You can see that what we've done is we've picked a tangent angle that allows us to cover the tumor bed and minimize the LAD and miss the LAD in its entirety. And now this is a nice solution, but the downside is if we really believe that the whole breast is a meaningful target, we're actually not treating a lot of the breast tissue that's medial. And so what we can do to fix that problem is add a medial breast field, which in this case, the dosimetrist is called an IMC field, but it's not an IMC field, it's actually a medial breast field. And this will then deliver dose with an electron field to the medial breast tissue. And if we're smart about the way we design this, we can get good whole breast dose coverage and minimize the dose to the LAD. So to unpack this plan a little bit more, I'm just going to start by talking about tangents and how we design those. And so when I'm doing treatment planning, I have found that the best approach is to be a creature of habit and always do things the same way every time, and that helps to minimize the chances that you'll make a mistake. And just an advertisement for radiation oncology, some of the things that we do can seem a little bit quirky or weird, or why did you do that, or why do you care about this? But the decisions that we make when we're doing treatment planning, they literally have lifelong implications for our patients. And if we mess it up, patients can die because of mistakes we've made, either due to toxicity or due to recurrence because we haven't covered the right targets. And so it seems kind of casual. It's not like, you know, you're in the OR sewing the LAD on, or the saphenous vein onto the LAD to bypass a plaque, and you know the patient's going to die if you don't get it right. But the decisions we're making are no less important and no less vital to the patient and their long-term livelihood than that CT surgeon who's doing surgery to reverse a blockage. So, you know, it's fun to listen to music while you plan, you can chat with your friends, but at the end of the day, this is really the heart of what we do, and you got to get it right. So with that preaching aside, let's talk about tangents. So I'm going to show you this patient's medial tangent field, and we'll talk about what makes a good tangent field. So in our practice, very commonly, we use a non-divergent cranial border, and we use that for this patient. So what does that mean? that means that the top border of the tangent is basically a straight line matched on an axial slice. Why do you do that? Well, by doing that, it allows me to do a little bit better job of missing her arm. So that's a good thing. It also, if God forbid she were to have a lymph node recurrence, makes it a little bit easier to come back later and add a superclad field and treat her regional lymph nodes without overlap into the tangents. And let me show you what that looks like. So this is a sagittal slice of this patient's treatment plan. And so you can see here that the top edge of the tangents is essentially a straight line in an axial plane. And how do we do that? Well, we define a circular contour at the match line, which I've shown here in yellow. And we call that a border, just to show you that on the axial slices. Oops, why did it show up on the axial slices? There we go. So this is just a very simple, easy way to do it. So we've created this single contour, which is a ring. And then when we design our tangent fields, what we do is we angle the couch until this ring becomes a straight line. And so I'm gonna undo the dose here. So if we had a couch angle of 0, this is what it looks like. And so I typically set up my tangent beam to the right gantry angle, and then I just rotate the couch until I've made this ring a straight line. And that means that this ray, which is diverging at the top edge of my tangent fields, is diverging perfectly through this axial slice. So I've got the right couch kick to have a non-divergent cranial border. So what else do we look at? Well, we try to pick a gantry angle, which is defining this ray, the deep edge. And we try to pick that to minimize the amount of lung in the field, and we try to pick that so that the beam itself is not traversing through the cardiac silhouette. And so this was one of those more challenging tangent cases where we were able to come up with just the right beam pairing to optimize coverage of the target volume and keep this beam off of the cardiac silhouette. And so other things that we look at, so that's our gantry angle. We also can pick a collimator angle to try to balance the upper and lower coverage of the breast tissue and minimize the dose to the organs at risk. So if you do this collimator angle, you're not deep enough inferiorly, and you can see that you'd kind of be missing the tumor bed. Oops. If we did this collimator angle, we're going to be too deep and we're going to be treating the heart, and we're going to miss some superior breast tissue. So you want to get right in the sweet spot where you're covering what you need to cover. I think that's about where we were. Something right around there. Let me get this right, actually. Looking at the sagittal CT slice can help you to match your two beams perfectly. So that's perfect. That's what we were at before. A way to think about it is you could think of this deep angle or this deep edge of the tangent field relative to the chest wall as equivalent to basically this is a bow and this is string on the bow. So like a bow and arrow if you're going to be shooting an arrow. So this would be the string and then this would be the bow. And so you kind of want it to be even like that. The superficial border is easy. You just want to flash the skin. And then inferiorly, I just put my inferior border where I put my wire to denote the inferior border. So typically that's about, as I said, maybe 8 millimeters in my practice from the inframammary sulcus, unless the patient has a very low tumor, in which case I'll put additional margin on the inframammary sulcus. When you're designing your fields, it's extremely helpful to take your contours and turn them on in three-dimensional rendering so that you can see how your beam is traversing relative to the target. And so that's what we've done here. Once you've designed your medial tangent beam and you're happy with that, then you have to design your lateral tangent beam. And so you would copy and oppose this beam to end up at a lateral tangent. Should I show them how we do that, or should I skip that part? Lauren says I can skip that. This is my patient's lateral tangent, so you can see we've angled the couch to get a non-divergent cranial border. We've angled the gantry to align the posterior divergence of the medial and lateral tangents. and we've adjusted the inferior border. And this is where I find that skin rendering to be helpful, because I can look to see where this beam is falling on the patient, and we can adjust the inferior border accordingly. So this is the wire that demarcated my inferior border, so my beam just goes at the edge of that wire. So these are great tangent beams. Now we can talk about the medial breast beam that's called IMC here. So this is what this looks like. This is what this looks like on the skin rendering. And so when you're treating a breast and you're matching a medial electron beam to tangents, typically we like to use a hinge angle of about 10 degrees. If you have a bigger hinge angle, say of 15 or 20 degrees, what's going to happen is you're going to have a cold spot that's too cold. So here's my cold triangle right here, which is the triangle created by the differences in divergence in these two fields. So if we have a 15 or 20 degree cold hinge angle, then this cold triangle gets too big. If we have a 0 degree hinge angle, then basically these fields overlap and you end up with a big hot spot in the breast. So 10 degree hinge angle seems to be a sweet spot. And what the heck do I mean by hinge angle? This is what I mean. This is the gantry angle of 312 degrees for the medial tangent beam. And this is the gantry angle for the IMC beam. So 312 for the tangent, 322 for the IMC, hinge angle of 10 degrees. And I planned this case a year and a half ago, and I didn't review all of this before presenting to you. So this is actually truly what we did. So let's just compute the dose again, and then I'll talk to you about plan evaluation. Alrighty. So when I review a breast plan, here we go. I personally, since I've already vetted all the beams and their angles, I like to turn the beams off because I find that they're a little bit distracting from reviewing the isodos lines. I like to zoom in a little bit so I can see what the heck we're doing. And our dosimetrists are really awesome, and they always print out the isodos lines with the same colors, and that's such a great strategy. I would advise wherever you work to make sure that you have a consistent pattern for isodos lines. So I know without looking at this, for example, that the yellow line is going to be the 90% isodos line. The blue line is typically, in these whole breast cases, the 7% hotspot. And 100% is in red. And so in this case, I'm using hypofractionated whole breast irradiation. I'm giving a dose of 40 gray and 15 fractions. I'm giving part of that dose through the electron field here, and then all this dose to the tangents. And so one of the challenges of evaluating these two plans together is that this electron field is contributing to a big hotspot in the breast, which is unfortunate, and there's not that much I can do about that. If I want to know if the dosimetrist did a good job just with the tangent beams alone, what I can do is just turn off the IMC prescription. So this IMC prescription was getting 349 monitor units a day. Here's your test of working memory. We're going to set that to 0 and see if we can remember that. This is the tangents alone, and what you can see is this is a very homogeneous plan. Just on this one axial slice, we have a teeny bit of a 4% hotspot, which is shown in green. We have very nice coverage of the whole breast, so typically I'll be looking at the purple line, which is the 98% isodos line, to make sure that circumscribes the breast tissue. That looks great. If the dosimetrist used all 18s, then typically the purple line would be pretty deep within the breast tissue, and you wouldn't have enough superficial coverage. And so without even looking at the energies, you kind of get a sense of is this too much high energy photons? And then I just like to scroll from top to bottom and keep an eye out for coverage and an eye out for hotspots. So in this plan, there's 4% hotspots that are kind of scattered throughout the breast, which is certainly acceptable. The coverage is good. We have one really low clip, but we've put a fair amount of dosimetric margin on that clip. So we have good coverage of the breast tissue. We don't have any 7% hotspots, and we have just some scattered 4% hotspots. So that's pretty good. In Pinnacle, you can see the max dose right here, which is 4238 centigrade, which is less than 7%, which is 4245. So that's really good. In general, for the breast plans, I try to keep my max hotspot around 107 or less. And in our hands, that's pretty much always doable. And we have a lot of patients who are very thick, as we would say in Texas. So this is a very nice tangent field. We've accomplished this using field and field dosimetry. So let's see. I'm going to show you the subfield. So we have a 16x photon field. And actually, I should get it this way. So we have an 18x photon field here. This is one of our field and field. So this is a field reduction, basically giving additional dose after we've given enough dose to the superficial breast tissue. And then one more field reduction, giving a little bit more dose. And then on the lateral, we have our 16 and 18x tangent beams, and then one field reduction here, and another field reduction here. And so in my mind, I just think of this as a fancy way of doing wedging, which takes into account the patient's unique anatomy. And the dosimetrist basically sets this up to minimize the hotspot. And this can be very effective and is also very fast to deliver on the machine. So that's kind of the plan review with regard to what the dosimetrist has done and the dose coverage. And so now we can go back to review the entire plan by itself. So we're going to turn the IMC field back on. So 349. And so now that beautiful tangent beam that the dosimetrist created has been ruined forever by this electron field, which is creating a not trivially sized hotspot in the breast. I'd have to say that's probably not the best thing for the cosmetic outcome. And I think patients treated like this probably have a little bit worse cosmetic outcome. But the real benefit here is that we've been able to get the LAD dose considerably lower. And you can see that we have really nice dose coverage of all the breast tissue, and we have good medial breast coverage, and the LAD is basically in the shadow of the electron field and is getting very low dose. And as far as picking out the right electron energy for this field, my goal was to cover down to the ribs, or at least the middle of the pectoralis muscle, and try to get the 50% isodose line here shown in green, to end within the chest wall and not extend into the lung. So this has turned out really nicely. You can see there's a little bit of a cold triangle, the cold triangle here, where the 45 or the 90% isodose line is not bridging this area, and instead we're bound by about the 70% isodose line here in purple, or 75%, I can't remember which, whatever 2804 out of 4005 is, I think that's 75%. But in any event, what we typically shoot for is that this purple isodose line doesn't break up where the fields match. And that's a reasonable kind of rule of thumb that we've used for years and seems to keep us out of trouble. So this is a very reasonable and acceptable plan, and this is indeed how this patient was treated. The final part of plan evaluation is to look at the DVH. And so here is her DVH. So as far as the tumor bed, the boost target, it's getting the full 40 gray and 15 fractions aside from a teeny tiny bit that's getting a slightly lower dose. So this is great. As a general rule of thumb, in any plan in any part of the body, if your target is covered well, and then basically the DVH goes straight down to some max point dose, this is a good plan. When you have a DVH that looks like this to your target that you're trying to cover, that means your plan is not very homogeneous with regard to target coverage, and you might want to try to re-optimize. In this patient, her mean heart dose is 82 centigrade, which is great. I was happy with that. But much more importantly, we were able to get her max LAD dose to be 7.4 gray, mean of 229 centigrade. And this is so much better than the tangent plan, where the max LAD dose probably would have been, if we were giving 40 and 20 fractions, 40 gray and 15 fractions probably would have been around 30 or 35. So this is, I think, a happy plan to lead to a great long-term outcome. I'll be long retired by the time these patients are having their cardiac events from radiation, but I don't want to hear about it from Lauren since she'll probably still be working. Excellent. So should we show the boost also, or?
We can.
Did you have other things you wanted to add?
No.
Okay, so let's see if we can show that boost as well. I don't even remember how we did her boost. Many tangents looks like. So I'm just going to prescribe this for 15 fractions. There we go. There are a gazillion different ways to do a boost. I've probably done most of them in my practice. For this patient, I wanted to give her a boost, and something's wrong. I put in the wrong dose. I opted to use mini tangents. And so generally for mini tangents, we try to cover the tumor bed, which in this case were the clips, and try to cover that with at least the 90% isodose line. So basically cover with an additional 9 gray and 5 fractions. The boost dose that's commonly used in the US these days is 10 gray and 5 fractions, which is an extrapolation from the EORTC boost trial, which used 16 gray and 8 fractions. But with electrons, we typically just cover with the 90% isodose line. So I'm mimicking something similar to that with photons. And in this case, I was just trying to cover the boost target, which is different than what we've conjured here. Let me turn on that target. There's our little boost target. So I believe we just kept the same isocenter and just shrank the fields down and just put a tight margin around the boost target. I can show you what one of those fields looked like. There you go. So yeah, we kept the same tangent isocenter and just put about a 1.3-ish centimeter margin from what we thought was our boost target to block edge. Very reasonable approach in a patient like this. If we had tried to use electrons, we could have come up with an electron energy that would have covered this target, but it would have been so high that a lot of the electrons would have streamed into the lung and heart, and it would have increased the LAD dose, whereas with this approach, we have no LAD dose.
We have a question from the audience.
All right.
Dr. Smith, since the patient had an oncoplastic surgery, does she still have a benefit from a boost? And isn't the tumor bed manipulated from the type of surgery that she had?
Those are great questions and things we wrestle with every day. So to unpack that, the first question is, do you have any clue in the world where is the boost target? And so, you know, surgeons vary in their degree of being trainable. And I've worked in many different environments with many different types of surgeons. We're very fortunate at MD Anderson to have some great surgeons who really want to do everything they can to optimize their patient's oncologic outcome. So we have trained them to put in tumor bed clips. And beyond that, and more importantly, God bless our plastic surgeons, because we had a conference meeting a couple years ago and we said, when you put in hemostasis clips, we have no freaking clue what's the tumor bed clips and what are the hemostasis clips, and so please stop. And amazingly, all 15 plastic surgeons stopped the next day. So that was so phenomenal. So we are very confident nowadays that when we simulate a patient who had an oncoplastic surgery at MD Anderson, whatever radio-opaque clips that we see in the breast are indeed actually defining the tumor bed and are not from the plastic surgeon. One little parenthetical comment is that every now and then calcifications can look like tumor bed clips, and that can make life complicated. That was a mistake I made when, in like 2011, when I was a junior attending. I contoured one calc that I thought was a clip, and the boost was big. And actually, the patient pointed out to me, and she was a physician, and I felt really sheepish about that. So we all make mistakes, but I've tried not to make that mistake again. One way to get around that is if you put the CT image on bone windows, oftentimes it's really easy to tell what's a calc and what's a clip, because the calcs won't be as bright. But yes, so you first of all have to decide in your heart, are you confident you have any clue where the tumor bed is? And if you don't have a clue where the tumor bed is, don't give a boost unless there's some crazy reason why you really think you need to give additional dose, and then you have to just boost a big area and guess and hope that it's right. The second question then is, where is the tumor bed, and is it in a volume that is boostable? So this is very gestalty and not necessarily evidence-based, but there's a reason, say, with conventional fractionation, we give 50 gray and 25 fractions to the whole breast and not 60 gray and 25 fractions to the whole breast. The breast can tolerate 50 gray pretty well. I think 54 gray is really the limit. If you go beyond 54 gray to the whole breast, you run the risk of causing a shriveled up, shrunken, fibrotic, yucky breast, which is so not the point of breast conserving therapy. So if your boost is going to be giant, you really need to think twice about giving a boost. That ends up being a very gestalty decision, and basically you can't get anybody to agree on how to quantitate that gestalty decision. I think it would be very reasonable to say that if you think this boost is going to be more than, say, at the very upper limit, a third of the breast tissue, preferably a quarter or less, then you probably shouldn't do it. There are those rare cases where I have patients with big tumors who had BCT, and I feel compelled to give them a boost, and I counsel them that they could have a bad cosmetic outcome because the boost is large. And I think half the time they're okay, but half the time they do not have a nice cosmetic outcome. So you have to be able to find the boost, and then know that you can treat it safely because it's confined to one area of breast tissue. And then it's just a matter of coming up with the best modality for delivering the boost to minimize the integral dose to the breast tissue and still cover the target, which in some cases I think is 3D. Rarely I'll do an IMRT boost. Most of the time I'll do an appositional electron boost, and we often will re-simulate our patients in funny positions and with funny angles to try to minimize the electron energy that we need to cover the boost target.
So we have a few more questions. Maybe
All right.
we'll do one and then we'll defer the other ones so we can get through another case. But
Great.
so the ASTRO consensus guidelines recommend keeping the 105% hotspots minimal. What would you define as minimal?
Yeah, those losers who wrote that guideline didn't really give any good clarity. Sorry, so I was the first author, so I can say that. That was something that we really debated a lot because everybody felt like there was a need for some sort of guidance, but there's not really any clear evidence as to what is the most appropriate dose metric for inhomogeneity. And I hope to write a paper on this one day. So we did a randomized clinical trial here comparing hypofrac and conventionally fractionated whole breast radiation. And to be quite honest, I just made up a dose constraint. And so the dose constraint I made up was the V108 less than or equal to 1 cc. And we were able to achieve that in the vast, vast majority of patients who we treated. And so we also, overall, at 3 years, our proportion of patients with adverse cosmetic outcome was 11%. It didn't differ by treatment arm. We presented that at San Antonio Breast last year. So I think, you know, to be honest, like I made that up when I was at the AACR ASCO Vail Cancer Clinical Trials Retreat. So that's not necessarily evidence-based, but now we have it in the literature as a reasonable dose constraint, which we used in a trial, and we generally had good cosmetic outcomes. So I think that's a very reasonable dose constraint. It's basically your Dmax of 107 or less, or V108 less than or equal to 1 cc. Some practices, like one of the representatives for the ASTRO guidelines said that their dose constraint was the V105 less than or equal to 200 cc's, which is actually really generous. And we went back and looked at that in our plans, and it's very, 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 very uncommon for us to have patients with a V105 greater than 200 cc's. So I think that's a too lax of a dose constraint. And I think in general, if you try to keep your max hotspot around 107, that's very reasonable.
Okay. And I think this one will be quick. So
Okay.
they asked, so at MD Anderson, why would this patient have also qualified for PBI since the tumor bed is well identified? I think her age was the...
Yeah, remind me how old she was?
48.
48, yeah. So I literally was almost late to this because I just spent the last hour talking to a 46-year-old woman with breast implants where I think PBI is probably the best option for her, which is a whole different story. But in general, we've been fairly conservative about using PBI, so we've mainly limited it to patients in their 50s, 60s, and 70s. Although the most recent ASTRO update of the guidelines put the patients in their 40s in the cautionary group, and there is some evidence that patients in their 40s with ER-positive, low-risk, mainly luminal A disease can do fine with PBI. So, but generally we haven't been doing it. It also kind of still freaks me out a little bit to do PBI in these patients who've had like real reduction mastopexies, because you don't really know if all the tumor bed is really next to those clips, and you don't really know if some of it could have been moved around further. So I would be very reluctant to do PBI in this patient for those two reasons.
Okay. So if you want to pause your screen, our case one should be ready for us. If
Ooh, great. Pause. Interesting. Okay. All right, we're back. Welcome back to case number 2. Dr. Colbert, did you want to present this patient?
Yeah. So this is a 61-year-old female with a clinical T3N3C invasive ductal carcinoma of the lower outer quadrant of the right breast. It was ER/PR negative and HER2 positive. She was started on neoadjuvant chemotherapy, but had 1 cycle of CCHP followed by 1 cycle of THP, and then had severe toxicity. So chemo was stopped, and she was re-imaged and appeared to have had an excellent response. So she went directly to a skin-sparing mastectomy with axillary dissection, which had negative margins and final pathology showing complete response. She was a YP-T0N0 with 13 nodes removed and negative.
Thank you. So really amazing story for this patient. Wanted to show just a few representative slices for her initial CT. So I trained at a great place, but in my 4 years of residency, never once did I see N3C disease. And I actually, in retrospect, I'm sure I did, but we just didn't look for it, and so we didn't see it. But this patient had N3C disease. I don't think we have a great image of the N3C disease, but here is an infraclav node. So that is a bona fide nodal metastasis from breast cancer. This is so important to know about as a radiation oncologist because very, 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 very few surgeons are actually going to dissect this space. And even if they do, I don't think you can really rely on surgery alone to remove a malignant lymph node like this. And so we always give these patients a boost to the infraclavicular region. You can also see she's got a really honking big right level 1 axillary lymph node and also this malignant level 2 axillary lymph node. This is a bit lower slice showing these lymph nodes are kind of clumped together. I bet you this would qualify as quote unquote matted. Matted is very much subjective and in the eye of the beholder, but I would say these are matted. You'll remember from your staging studying that matted makes you a clinical N2 as opposed to an N1. But this patient was N3C because we did an ultrasound, found a superclave node, and biopsy proved that. Is this after chemotherapy, Lauren? Mm-hmm. So again, this patient didn't get a lot of chemotherapy, but she had a great response. She's got almost nothing left in her axilla. You can see no infraclav disease. You can see, you can kind of tell that the chemo took a toll on her. So she's developed these small pleural effusions. So she had a mastectomy and had this amazing response to chemotherapy and passed CR. And so here's her plan. And so I'm gonna go through my approach to contouring this plan. So we'll turn the lines off for a second. Maybe that's okay. So what do we contour? So you know, there's lots of different approaches to these cases, and I can tell you if you're going to enroll a patient on a big clinical trial, you could spend a ton of time contouring, and there's nothing at all wrong with that. With the exception that I have a bunch of kids and I need to get home by 6 because the nanny's ready to leave. So I need the faster way to do treatment planning, and so do my colleagues for that matter. So I'm going to walk you through what we do, and it's very fast and efficient. So I contour the axillary apex. So I remember I pointed out those lymph nodes that we can't really trust the surgeon to remove completely. And so we contour those here, and that serves as a guide. Generally, what I'm contouring is I'm looking to see where did the surgeon stop their dissection. This surgeon left me a lot of clips. I can pretty much tell she stopped right here. So now I'm going to contour the level 3, which is essentially the lymph node bearing tissue, which is superior and medial to the edge of the surgeon's dissection. I'm using her initial CT scan to help inform my understanding of where her malignant nodes were in this region. So typically what I do is I contour medial to the pec minor, deep to the pec major, up to the clavicle, and all the way down to about the ribs. Now, this isn't my only target because I also want to target rotor space in this patient, but just to kind of make things clean and simple, this is typically what I contour. And then we contour the internal mammary lymph node. Oh, in this patient, I'm not sure if I contoured the superclave nodes or not. Looks like I did not contour the superclave lymph nodes, but I definitely intended to cover them completely. We have an auto contour for the brachial plexus to kind of keep track of that dose. And then we also contour the IMC vessels. So here's the IMC vessels coming off of this artery. and they come up here, and then they get into the space here between the sternum and the ribs. What I typically do is just contour the vessels, and then I design my field to cover the vessels with a adequate radial margin on either side. And I typically start at about the bottom of the first rib. So here's the first rib. There's the bottom of the first rib. This is where I started my contour. And then I go down to the top of the fourth rib. I'm not sure what that's doing. I think I don't know, it looks like there's some clip that got there somehow. I contoured that as well. So we come down to the bottom of the fourth rib, which is going to be about right there. If you have somebody helping you to contour these, it's very common for them to make a mistake and contour too much or too little. One very easy way to validate that is just to look at the sagittal. So here, first interspace, second interspace, third interspace. Very obvious, nice, clean way to check your contour. So now that we've done just a little bit of very simple contouring, obviously, now we can start to put our fields on. And so we already kind of talked about isocenters on the last case, so we're going to skip that, and we're going to talk about our field. So again, I always set up my windows the same way to minimize mistakes. So I like to look at my DRR in this window, my skin rendering in this window, and my axial CT slice in this window. Combining all these together is very helpful because each tells you something a little bit different about the patient. When we simmed her, I marked, or probably Lauren marked because I wasn't doing any work, the scar and the borders. So I typically just mark medial. I look at the other breast and the contralateral inframammary sulcus, and in my mind kind of place it on this side, and then I like to put at least about a 2 centimeter margin from where the breast was sitting down to my inferior field edge, which I've marked with radio opaque wire here. And then I often will put posterolateral marker. I can't quite tell if I marked her drain sites or not, but it would be very common for me to mark the drain sites in a patient with T4 disease. As far as the field design, this is my supraclavicular field. So she had N3C disease. And so in the setting of N3C disease, we like to go higher and cover close-ish to the mastoids. So I went close. I at least went up a little bit into her mandible. And so let's take a look at that. I always start with the supraclav field because you can design this separately and independently from the other fields. So supraclav field, how do we set this up? So superiorly for this patient with supraclav disease, I went up pretty high. So here's the tip of the mastoid. I'm trying to point to it with my finger. I don't think that's going to work. Here's the tip of the mastoid right there. And so as we go right there, we come down a little bit. So here's the bottom of the parotid gland. So I didn't really want to give her xerostomia. So I set the top of my field right kind of at the bottom of her parotid gland. I tried to minimize coverage of at least a good chunk of her submandibular gland to try to minimize xerostomia. And the idea here is basically the lymph nodes that are sitting along the carotid and the jugular vein and deep to the sternum are the target up here. This is kind of an MD Anderson thing. Lots of centers don't go this high for N3C disease, but I think it's reasonable, and certainly we see weird things happen when you don't go high enough in N3C disease. As you come down medially, I'm basically hugging the pharynx and the hypopharynx. I try not to treat the thyroid cartilage. I was a singer in a former life, so I hate to make people not be able to sing after radiation. And you don't need to go further than this. Basically, your target here is the vessels and the fat deep to the sternocleidomastoid for your medial border. Now, the inferior border of the match line is something very important and something that people screw up. For example, I've reviewed way too many treatment plans over the years where people put their inferior border right there. So you know the problem with that, I can't turn the contour on right now because we are having a confidentiality issue on the contours page, but the problem with that is this patient had her malignant node right there. And if you put your border that high, unless you do something wonky with your tangents, you're totally going to miss that space. And so that's really bad and wrong. But it's really simple. As long as you put your inferior border essentially right about the bottom of the head of the clavicle, you can't screw up. And so here you can actually kind of see the clavicle comes down to right here. I have my inferior border at the bottom of my head of the clavicle, and we are good. We know the supraclavicular lymph nodes live here. We're covering those nicely. We're going up high in the neck. And then as far as laterally, what we do at MD Anderson is remember I said I wanted to cover rudder space, but I didn't actually contour it. But what I do is I look at my lateral border here, and I go to about the lateral edge of the pec major. And if I do that, then I know that I'm confidently covering rudder space. That also gives you a little bit more margin on the chest wall up here. So that's kind of a nice approach. Now, where I trained, we called this field treating the axilla. And if we put the lateral border here between the humeral head and the coracoid process, I guess that would be right there, we called that a supraclav field. Now, I'm not trying to be critical of anybody, but I was confused to no end for like years, because this is how I was trained what a supraclav field was. And then I would talk to my friends at MD Anderson, and they're like, oh, this is a supraclav field. And and then my attending said, oh, you're covering the axilla here, and this is going to be really morbid, and so never do it. So this points out some of the frustrations and the challenges with our field of kind of like actually clearly saying what the heck it is we're doing. I think that for patients with locally advanced disease, this approach is very nice because it makes sure that you cover the rotor space. And that is a space where patients definitely can have malignant lymph nodes. It's also a space that surgeons rarely dissect. Even when they say they've dissected it, I don't think they've really dissected it. They just kind of mucked around in there a little bit. You can't really dissect that space unless you remove the pec minor. So in my mind, for a patient with more locally advanced disease, it makes a heck of a lot of sense to have Rotter's nose as one of your targets. And to do that, you need to come out like this. I also would say I don't think that this field in and of itself increases morbidity drastically, although patients do tend to have a little bit more of fibrosis of the pec muscle, and they need to be nagged to do range of motion stretching exercises to make sure that doesn't become too bad for them. In our practice, when we're quote unquote treating the axilla, what we do is we actually contour this whole axillary space, and then we'll add a supplement either from the front, an anterior axillary supplement, or the back, which is often called a PAB or posterior axillary boost, to make sure that the minimum dose to the axilla is 45 gray. And one way to think about that is you're trying to get your 45 gray isodose line to come down to here, the anterior margin of the subscapularis muscle. So that's just a sort of a divergence to talk about nomenclature, but I think very helpful, hopefully, to understand differences in practice. So this is a great supraclav field. We're going to briefly look at the tangents. We kind of went over the meat of that before. So here's another nice tangent field. You can see on this one, we put a wedge. We have a non-divergent cranial border, which is matched to the tangent, the inferior border of the supraclav field. We have about the right amount of lung in this field, not too much, not too little, about a cm to a cm and a half. We have nice broad coverage of the chest wall. And when we scroll through, we have nice chest wall coverage here too. The goal here is that our IMC electron field is going to be about 5-ish centimeters wide. If it's much wider than that, you end up with a lot of lung dose penetrating from the electron field, and that makes your DVH when you're playing kind of crappy. So this is a nice tangent field. I would point out, so let's get to the slice with her. So this patient, this lovely patient, is shaped like many Texan women, and her scar comes all the way out to here. So if we wanted to cover her IM nodes, which I would say if there's anybody you should cover them electively on, it's this patient with N3C disease. If you're not going to use electron photon technique and you want to cover that scar, this is what you got to do. So that's what your tangent fields would have to look like. And I cannot think that in good conscience you could treat that much lung with partially wide tangents. So this is just a great example of how You can't use partially wide tangents to treat everybody, and electron photon technique is just way, 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 way better than partially wide tangents. The VMAT would be another approach which could give you very nice conformal high dose. The problem with VMAT is that you're going to end up spraying a lot of dose into the lung, and then your whole thorax doses can get into meaningful ranges where you might be significantly increasing the risk of second malignancy. So I think this is a really great planning approach for this type of patient. To put her IMC, show her IMC fields real quick. Here's her, we split her IMC into 2 different fields, an upper with a higher energy, a lower with a lower energy. That's a very nice approach to deal with treating the medial chest wall in the IMC. Here it is in 2D. You can see this nice field. This field is pretty much exactly 5 centimeters wide, exactly what I wanted. I can't turn on the IMC contra in 3D right now, but let me tell you, it's pretty much right in the middle of this field, which is great. My hinge angle is 15 degrees. We use 15 when we're treating a chest wall, 10 when we're treating an intact breast. So this is a great beam configuration that looks really nice. We're going to turn these beams off into 2D. We're going to go to the axial slices, and we're going to turn the targets on, the isodose lines on, maybe. Why is that not working?
I think you have to recompute the.
Oh, thanks for my message. Oh, yeah. Sorry. Okay, so we can scroll through this plan quickly. I've never gotten through 4 cases in an hour in my whole life, Lauren. So here we go. So I'm trying to cover my nodal targets with my 45 gray isodose line shown in yellow. I'm trying to cover my chest wall with about my 49 gray isodose line, which is shown in purple. And so here we go, starting at the top. We're just barely kind of covering this nodal pocket here. Honestly, a little bit more mandible dose than I would love, but it's kind of what I was stuck with. I couldn't otherwise get her chin easily out of the field. It's nice coverage of the supraclavicular lymph nodes, nice coverage of the infraclavicular lymph nodes. Here's my Rotter space coverage, covering that purple contour, which is really important in this plan. And then we get down to the chest wall. So the downside of the chest wall is my 110 isodose line is shown in blue, and there's a pretty big hotspot of 110. This is a downside of electron photon technique. And then I also have a cold spot here. So my 40 gray isodose line is breaking up. So on any given day, there's an area of tissue that if it was treated exactly the same way every day, would be getting less than 40 gray in the chest wall, which I would agree if somebody criticized that as being too cool. I think what happens is that day to day, this cold spot gets feathered out, and probably the hot spot, but to a lesser extent. And as a result, we really never see failures at the match line. So I think it's reasonable, but it is a limitation of this technique. But the bright side of this technique is that we're able to cover broadly this chest wall and the internal mammary lymph nodes and still have a very reasonable heart dose and a very reasonable lung dose. If we go to the DVH, so some of the things I look at the DVH, the brachial plexus, I kept the hot spots off the plexus, that's good. I wanted to cover my right IMC and axillary apex with a minimum of 45 gray. Both are covered nicely with a minimum of 45 gray. My right lung dose. So there's no great data in the literature about the optimal metrics, but what I typically try to do is keep my V20 at least less than 35%. We treat more and more patients in breath hold, and with breath hold, you can often keep it less than 25 to 30%, but this is reasonable. This patient had no lung problems at all. So her V20 was like 31%. Her mean heart dose is very nice. It's 181 centigrade. I don't tend to pay attention to the max heart dose. I mainly just look at the mean in my evaluations. Generally, the mean's quite good. You could also look at a V10 or a V20, but generally those are quite low and not that informative. So this is a nice DVH that we were happy with. Interesting story, we treated this patient, she did great. She came back for follow-up and she literally seized in my clinic and we transferred her to the EC where she was found to have a brain metastasis. And it illustrates one of the like very humbling challenges of treating HER2 positive disease is that there's this subset of patients where the brain is a sanctuary site and they do great and they have these miraculous responses to systemic therapy only to fail in the one place where Herceptin can't get to, which is really sad. And I'm sure there are people smarter than me working on better strategies for that particular problem. Do you have more questions?
Not yet for this one. And I think we're about out of time.
Yeah.
But if people have additional questions, feel free to send them and we'll answer them in the posted version of the webinar.
On behalf of ASTRO, I would like to thank you all for participating in today's event and extend a special thank you to our speakers, Dr. Smith, Dr. Gifford, and Dr. Colbert. To learn more about ASTRO-ARRO's upcoming on-demand webinars, please visit the website at www.arro.org and navigate to the ARRO Del Regato webinar series under Educational Resources. After logging out of this webinar, a webinar evaluation will appear in a separate browser window. Please take a moment to provide us with feedback on today's presentation. It will help us better meet the needs of residents. This concludes today's program, and thank you very much for joining.
Thank you.
Thank you.